All right, welcome to the Explainer. Today, we're throwing on our medical detective hats. We're looking at a seemingly common symptom, chronic constipation, but we're going to approach it with the absolute rigor of a forensic investigation. The goal here isn't just to throw treatments at a wall and see what sticks, it's to uncover the actual physiological culprit. Our guiding star today is the golden principle. Correct subtype identification is the absolute key to effective, targeted treatment.
Okay, let's dive right in. We've got this massive, comprehensive 8-step clinical roadmap for diagnosing and managing constipation. It might look kind of overwhelming at first glance with all its different branches and color codes, but over the next few minutes, we're going to zoom in and decode this stepwise clinical algorithm. By the end of this explainer, you'll see exactly how this highly structured approach prevents clinical missteps and leads directly to patient relief.
So here's our agenda for today. We'll hit identifying red flags early, the first-line therapeutic trial, advanced anorectal diagnostics, tracking colonic transit, targeted treatment strategies, and finally, special situations and pitfalls. Let's get to it. Section 1. Identifying red flags early. Securing the scene. In any good investigation, the absolute first priority is securing the scene, right? Before we even think about treating the symptom, we've got to make sure there isn't a life-threatening structural danger lurking in the background. So step 1 of the algorithm is all about ruling out organic disease by checking for these alarm features. We're talking weight loss, anemia, hematochezia, blood in the stool, new onset constipation if the patient is over 50, or a family history of colorectal cancer. If literally any of these pop up, boom, our detective work takes an immediate detour. That patient needs a colonoscopy straight away.
Now, if the scene is totally clear of red flags, we move right along to step 2, the initial clinical assessment. You take a history, check the Bristol stool scale, look out for drug history like opioid use. But here is the absolutely mandatory physical exam, the digital rectal examination, or DRE. We have to assess perineal descent, sphincter tone, and simulated evacuation. But hold on a second. Here's the kicker. A normal DRE does not rule out dyssynergia or an outlet obstruction. I mean, it's a super vital screening tool for sure, but it is absolutely not the final word.
Section 2. The first-line therapeutic trial, the standard protocol. Okay, so if basic investigations are completely clear, we don't just jump straight into expensive invasive tests. We initiate the standard protocol. And right at the top of step 4, there's a very specific, absolutely crucial number, 12. This first-line therapeutic trial requires a strict minimum of 12 weeks. You just have to give the body time to respond. Having a little patience here actually prevents premature escalation. During those 12 weeks, we deploy 3 non-negotiable pillars of basic lifestyle modification. First up, fiber. We're aiming for 25 to 30 grams a day, whether that's through foods or supplements. Second, fluids. We really want to increase intake here, specifically with magnesium-rich mineral water, if possible. And third, physical activity. Getting regular exercise. Now, sure, the evidence on exercise can kind of be conflicting sometimes, but the overall benefits make it a totally crucial part of this foundational step. Alongside those lifestyle changes, we bring in the over-the-counter laxatives. And the algorithm brilliantly breaks down the evidence-based hierarchy here, splitting them into strong recommendations versus conditional. Polyethylene glycol, or PEG, is our first-line osmotic champion. It's strongly recommended, costs like $1 a day, right up there with sodium picosulfate. Now contrast that solid confidence with the conditional options, things like lactulose, senna, or bisacodyl suppositories. Those are often administered pretty cautiously, usually about 30 minutes after meals, just to synergize with the body's natural gastrocolonic response. Section 3. Advanced anorectal diagnostics, deep forensics. So what happens if there's zero response after our 12-week trial? Well, the investigation gets intense. We enter deep forensics. But if you look closely at the algorithm, it gives a very strict directive for step 5. Perform anorectal testing first, before you even think about a colonic transit study. Which really begs the question, why investigate the exit before checking the plumbing? Well, the algorithm gives us the exact clinical rationale. Defecatory disorders are literally twice as common as slow transit. Plus, slow transit might actually improve once an outlet obstruction is treated. I mean, think about it like a factory line. If the exit doors are blocked, the whole assembly line backs up and slows down. And, most importantly, the treatments for these two subtypes are fundamentally completely different. To find the exact anomaly, we bring out the high-tech forensic tools. We have 3 main tests in step 5.
First, the balloon expulsion test. That acts as our simple frontline screening. Next, anorectal manometry. Gets a bit more technical, assessing the specific sphincter pressures and rectoanal coordination. And finally, defecography, which uses fluoroscopy or an MRI to give us the hard visual evidence of any structural abnormalities, like a rectocele or an anorocele.
Section 4. Tracking colonic transit, the flow rate. All right, let's say our deep forensics reveal no defecatory disorder. The exit is totally clear. Only then do we pivot to evaluate the actual flow rate. We conduct a colonic transit study, typically using radiopaque SITS markers, and this hard data literally splits our investigative path. If the transit time is well documented, anywhere between 20 and 72 hours, we categorize that as normal transit, which routes us directly to step 7A. But if those markers take longer than 72 hours, we've got delayed transit, which sends us right down the path of step 7B.
Section 5. Targeted treatment strategies, the final takedown.
This is it, the resolution phase. We've done the detective work, we've isolated the physiological culprit, and now we execute the final takedown based on our confirmed subtype. If step 5 revealed an outlet obstruction, we're operating in step 6A. Here, biofeedback therapy is absolutely the treatment of choice. It boasts a greater than 70% success rate from motivated patients. Now, if there's a structural lesion, we might have to consider surgical correction. But here is the massive takeaway. Do not use laxatives as the primary treatment here. It's going to fail because, honestly, you're literally trying to push against a closed door. Now, if we found normal transit, we're in step 7A, functional constipation. We continue with those optimized laxatives and start considering strong recommendation prescription agents like linaclotide or pliconatide. Contrast this with step 7B, slow transit constipation. Medical management here escalates to prokinetics, like prugalopride. If medical therapy completely fails, well, this is where highly selective surgical options come into play, representing only about 5% of cases. We're talking major, life-altering interventions, like a total colectomy with an ileorectal anastomosis. But obviously, that's only after a strict psychological evaluation and completely ruling out upper GI dysmotility. But what if a patient has both? Step 8 outlines the protocol for a mixed disorder. That's dyssynergia combined with slow transit. It requires a really methodical 3-step sequence. Step 1, you treat the outlet obstruction first using biofeedback. Step 2, you reassess the symptoms and the transit time. Step 3, only if the slow transit persists after the exit is completely clear do you manage it as slow transit constipation.
Section 6. Special situations and pitfalls, the postmortem.
As any good investigator knows, no two cases are exactly identical, so we have to adjust our framework for unique scenarios and stick to the non-negotiable rules of the clinical road. For opioid-induced constipation, avoid bulk laxatives. They'll seriously just cause bloating. And instead, add PAMRAs. For fecal impaction, immediate physical intervention is required, digital disimpaction and enemas. And for our elderly patients, the golden rule is doing a really thorough medication review to avoid polypharmacy and always remember to start low and go slow. Finally, the bottom of our map explicitly lists the absolute clinical guardrails, the what not to do. These are so critical. Number 1, never order a colonic transit study before anorectal testing. Number 2, never treat dyssynergia with laxatives alone. And number 3, never, ever operate without first excluding global GI dysmotility. Violating these pitfalls just leads to failed treatments and prolonged patient suffering, which is exactly what we're trying to avoid. Which brings our investigation full circle, right back to the guiding light of this entire algorithm. Correct subtype identification is the absolute key to effective, targeted treatment. It's not just about knowing the drugs, it's about deploying them at the exact right moment for the exact right physiological reason. So I'm going to leave you with this thought. Based on this rigorous, stepwise medical detective framework, how will you approach your very next chronic constipation case differently? Are you going to jump straight to writing prescriptions, or will you follow the clues, secure the scene, and isolate the true culprit first? Thanks so much for joining me on this explainer. Until next time, keep investigating, keep learning, and trust the algorithm.